All right, let me share my screen with all of you here. Very good. Slideshow. All right. Welcome, everybody. It's great to have all of you here, and thank you for joining us. All right. If you don't know me, I'm Dr. Lenny Carneiro, physical therapist, doctor in physical therapy. I'm also board certified in geriatric physical therapy, and I have been working with Parkinson's disease closely since 2012. So we're approaching like 12 years. And then one of my passions, it's kind of like share, the information that we know and, get an update currently. So our patients can, and caregivers and their families can have the best management of the care, and that's very solid when you, especially dealing with a chronic neurological disease, you have to be on top of your game for that. And that's the purpose of it, help you folks to always, give you a little bit more a piece of information so you can excel on your journey with a neurological condition like Parkinson's disease. All right. The topic today, we're going to talk about, the PD diagnosis, how the PD diagnosis is made, and then, the stages related to that and how we can care and also have a approach in place for each stage. Okay. So wrapping up PD diagnosis and caring for each stage. The learning objectives here, it's always about the disease, okay, in its stage, how to measure the progression from each stage to the other, especially coming from, the mindset of physician, like what they look for, for proper diagnosis, and learn how to effectively care for each stage. So we're not here to seek for medical advice, just informational content, so guys can take notes and also discuss that with your primary care physician, your neurologist, or even your movement disorder specialist. Okay. So what is Parkinson's disease? Let me change here my screen because it's kind of like on my way of reading. Okay, let me see here. All right. So Parkinson's disease. Parkinson's disease is a progressive disease that gets worse throughout the time. All right. Which is marked by the tremor, muscular rigidity, and is low, imprecise movement, chiefly affecting middle-aged and elderly people. All right. We know it's mostly related, like it's not aging disease. When you get older, you have more chance to have it. However, we have, young onsets, which we're going to talk about that. People, under 40s, 30s, even, teenagers presenting symptoms with Parkinson's disease. Okay, it's getting more and more common. And also, that disease is associated with the degeneration of the basal ganglia. As you see here, the basal ganglia is this part of the brain here in I would say light blue, okay, that is responsible for the production of dopamine. Dopamine is a neurotransmitter that is related to movement. That's why it's called movement disorder. The dopamine helps us to move. So the brain produces that on a basal ganglia, okay? And once you have that available in your system, you move better. With Parkinson's disease, there's some deficiency on a machine, to produce more neurons, more, I would say, more dopamine through the neurons. Some of them dying, some of them don't perform well, and the lack of dopamine is present, and once you don't have that available in your system, then you can have what is called a movement disorder. So the movements of your body will be affected, okay? Oops, so sorry. I don't want that. And then this is an example here, so we can just have a picture, okay? The upper picture here on the screen, the health substantia nigra, So the dopamine has this aspect, when you have a healthy brain, you have this area more like in dark spot. That's why it's called nigra. Okay. And then because there's some deficiency of the production of the dopamine in that area becomes a little bit more less dark, a little more, less evident, and that's where we know the deficiency is taking the place. Okay, staying in place. Just like a little bit about the information, for the graphics, so you can see it. All right. So here we go. Parkinson's. So we know Parkinson's affects mostly, the movements. Okay, so the motor aspect of Parkinson's disease is more visible, which is kind of like the graphics here, which I love, that shows the iceberg. Okay, and we know when you see an iceberg, you're just able to see the top of it, above the sea level. However, the structure underneath, it's way thicker, stronger, that's much more in depth, when you talk about iceberg. So the motor symptoms are the ones that are more visible. So we are able to see them. Okay, we are able to, like with our eyes, catch them. All right, catch them. And then we cannot forget, there's some no motor symptoms. Those ones that, like, it's not that visible, but perhaps they're already happening. All right, the ones that are more visible, you start with the tremors, or you see that, it's kind of like this pin rolling, on the hands mostly, okay? And then some rigidity, feel like stiff, doesn't move well, or the slowness, the patients are moving, but perhaps, the quality of the movement gets shorter, smaller, and then there's some postural imbalance, okay, causes some balance deficit in those things. So those are the ones that we see, and mostly are the ones that usually what calls people attention regarding, oh, maybe there's something wrong, maybe I should see a doctor, or maybe, for example, I have a recent diagnosed patients that a patient that I'm working with, his primary care just notices something different as he was walking. He was not swinging his arm, and it was like, you know what? I think you should see a neurologist. And he went, saw the neurologist. The neurologists just go more in depth, for the problems that might be involved, might be there, but the patients perhaps are not aware that's happening. And later on, he was diagnosed with Parkinson's. So those, the motor symptoms are the ones that usually cause people attention, all right? But we have other ones that sometimes can be, driven the care, especially the lack of smelling and constipation are the cardinal signs that usually people gets, searches for the care, in a way that they see if something's wrong with them. As you see, there's a lot of things involved that could be related to Parkinson's. Maybe you might not think that's related. That's why seeing a neurologist, and especially movement disorder specialist, will make like a big difference for you to properly be diagnosed and manage, the disease afterwards. Okay. So what caused PD? So we still don't know. What we know, definitely the research backs up on that one. On that aspect is like, the Parkinson's is related, to a combination of environment, okay, and genetic factors. Actually, I would say three: environment, genetic factors, and aging. All right, so environment, being exposed to pesticides or solvents, well water drinking, head injuries like TBIs, and then genetic factors like mutations in some genes. So the research now, it's really getting heavy regarding the study of the gene mutations, getting more and more genes related to Parkinson's, and that's going to help us later on to find best, approach for the care. And then aging. So as we get older, we have more chance to fall under the diagnosis of Parkinson's disease. Okay. For the environment, we know, okay, pesticides, insecticides, those things, that it's used to kill the bugs and stuff, they are pretty heavy, with some correlation with Parkinson's disease, manganese exposure, and other solvents are very solid with some correlation with Parkinson's disease. Okay. And then the average regarding the aging aspect, the average of diagnosis, it's around 60s, However, as we mentioned, some people can get Parkinson's even younger, and those are called young onset, all right, with the disease. We have more men, diagnosed versus women. We have 1.5 ratio difference, and then more whites versus other races with the disease. And how the diagnosis is processed, there is no blood test, no brain scan, or other tests that can be really like used and remarkable to be like totally on top of the diagnosis. Okay. Mostly the diagnosis is done, especially clinically, meaning like the patient will come with some, concerns, some things that, they feel like it's not doing right, and based on that, perhaps the medical history and the physical examination that the doctor will proceed, will come up with the diagnosis. Okay, so, and for them to be a little bit more on top of the diagnosis of Parkinson's, there's some criteria, meaning like they have to be under the motor Parkinsonism, which is the core of the feature, which involves bradykinesia. Bradykinesia is a medical terminology that goes towards like slowliness. So the movements, get smaller and slower, right? They lose quality and powerness of the movements, plus resting tremors or rigidity. Okay, resting tremors, like you want to do something, and then when you kind of like stop the activity of the movement and the shakiness, it's present. Perhaps just a little twink there, it's enough to already, be established as a resting tremor. Or rigidity, there's some lack of flexibility, and then some lack of range of motion, affecting overall the mobility. So for the doctors to kind of like, be firm regarding the diagnosis, at least that's how they start. There's a lot of things, red flags or exclusion criteria that they have to work on it, and rule in and rule out to go around the diagnosis, but the core are those things: bradykinesia, resting tremors, or rigidity. Okay. And this is just going to show you, about imaging of the brain. Unfortunately, it doesn't always work like that. That's why there's no brain image that will show, for all Parkinson's patients that there's a disease there. However, for some patients, the DET scan shows that. That's why sometimes the doctors, even though not knowing if they're going to be shown there, some patients it's feasible. All right, so and shows there like the difference between the health brain, which is more like you see the colors are more vivid, on the right corner like orange, and then with the death of the cells of the neurons and the production of the dopamine, it becomes less vivid. Okay, and the same here on the left corner. Okay, how the DET scan from a normal brain patient versus a person with Parkinsonian syndrome. Okay, All right, so I want you to just pay attention to this slide because that's a lot of information, okay? I want you to focus right here in the middle of the of the screen of this slide, okay, the picture. We have two aspects here. We have, you know, let me go back a little bit. On the left side of the picture, we have the degree of disability, and then on the bottom, you have the time, okay, the years with Parkinson's, all right? So we know when patients come with, the diagnosis from that day, we know already, just remember about the iceberg, okay? So you have like some of the motor symptoms that's happening, all right? Going to always be to be more, educational, focus on those three ones: the bradykinesia, rigidity, and tremors, because those are the core ones, plus other things that the doctors will investigate. So when those three symptoms, or two of them at least, are presented, it's when the diagnosis is made. However, there is like a period a little bit before, when the symptoms, the motor symptoms were presented. And even before that, what's called the prodromal, a stage, it's when, the non-motor symptoms were presented, but there was no correlation yet with Parkinson's. Perhaps the constipation, perhaps the hypoposmia, which is the lack of smelling, okay? Some sleep problems with the rapid eye movement, sleep behavior when those that have the active dreams, like, when they sleep, they really like kick their spouse, or have like, they simulate some motion as they were sleeping. So those things, they can be presented, for long years. They can go like all the way back to, 20 years. And then that's what it's part of, like, what we don't see underneath the iceberg, and you don't think it's related to Parkinson's. But once the motor symptoms are there, we know already, that's something underneath happening place. And that's when we investigate, the doctors investigate about the depression, anxiety, constipation, lack of smelling, those things, or the sleep problems. They have been presented for quite a while, okay? And then from the diagnosis and on, we're going to separate the disease in different stages, okay? Here, we will be back on this slide if it's needed, okay? And then here, it's going to show you, here in the center is the clinical set, like when the diagnosis was made, okay? So the Parkinson's is real, you have that, or you have Parkinsonism, meaning like you don't have all the features that Parkinson's requires, okay? However, there's some features that, can be related to that, and that's why they don't close the diagnosis yet. They call Parkinsonism, okay? I'm going to need somebody to, I don't know who, to unmute themselves. Let me see if I can go here. All right, I did. Perfect. All right, so and then see, like, oops, let me go back here. The clinical set, it's happening there. And then from the clinical set, we're going to develop the stage. But before, see, like, you can go all the way back from the clinical set, perhaps 10 years, 20 years, when other symptoms were presented, but there was no, correlation yet with Parkinson's disease. But the disease was already, starting, becoming place, okay? And then after that, the motor aspect is more evident, and that's when, those things kind of like trigger the care, all right, for more a better approach, okay? And then, let me go back a little bit just to give a little bit more insight. So once the diagnosis is made, okay, and then that's called clinical onset, we start from there going on stages, all right? So now we know Parkinson's disease is there. the diagnosis is there. Now what we're going to do? So where am I regarding, the stage of the disease? All right. And there we have like 5 stages based on the, it's called Honig ER scale. Okay. The Honig ER scale helps us as healthcare providers to establish like a game plan for each stage. Okay. I'm going to talk about every stage here. The first stage, it's only one side involved of the body. Okay. Mostly just like a mild tremors, on my hand, or I feel a bit stiff, perhaps, when the patient's walking, is not swinging the right arm, but everything else is fine. Feel a little bit stiff here and there, they might pick some sort of like slowness, but as you see, it's just very, very mild, and mostly starts with one side of the body. Okay, and then comes the second stage. The second stage when the disease progresses a little bit more. Okay, and then not just one side is affected, but now both sides. Okay, and now the tremors are more evident in both hands. Okay, the rigidity, the stiffness that the Parkinson's patient might develop, is more presented. So they start complaining about, dead more often, and they see the quality of their movement, it's become poorer, more poorer. Okay, so they're perhaps moving slower, moving with less, quality. For example, when they're walking, they're kind of like, shortening the step length, the posture is a little bit more stooped, those things can be more presented. Okay, and then we go to the stage 3. The stage 3, it's when, we just like piling up things. Okay, so the tremors and rigidity bradykinesia are there. All right, they're getting a little bit more evident, a little bit more worse. Medications are needed to kind of like manage them, perhaps a little bit more here and there. Some tweaks from the doctors. Okay, and then on the stage 3, when balance is compromised, there's some postural instability, and then some falls start happening. Okay, perhaps silly falls, perhaps falls that feel like, this was nothing, or just not pay attention, oh, this was not something like major. All right, those things, So when those things happen, we've figured out like we are going towards the stage 3. All right, the mobility is getting a little bit worse, the posture is getting a bit more stooped, and then there's some balance deficits. Okay, at this stage, sometimes, we start like advocating for some assistive device, not for everybody, but sometimes people might need it. However, when we go to the stage 4, assistive device is needed because, now the symptoms are pretty much presented, on a spectrum, very, very solid. It's getting a little bit more hard to manage the disease, and now patients are having problems, for example, to walk distance or even to stand up, independently. So on a stage 4, the assistive device needs to be there for safety. Okay, otherwise the patients will fall. Okay, and more care around the patients needed, especially from the caregiver side, like husbands, wives, partners. They'll need to be more on top of the patient to make sure the activities are done, and then the patients can still be mobile, but it needs a little bit more supervision, I would say, and sometimes a little bit more assistance from the caretaker aspect. Okay, and the stage 5, it's when the system, it's totally needed. We have more disability coming from stage 4 to stage 5 in place. Around the clock care is needed, and patients, they prefer mostly stay on a wheelchair because it's safer, or sometimes it's just too hard for them to walk. and then, wheelchair, it's better for them to move around. Okay, so those are the stages that we work on it. All right. And then how we monitor the progression. So the doctors are the ones responsible for that. So people, we know about it, and especially, work with patients on a regular basis, 2, 3 times a week. We get this question very often, like which stage I am, those things. But though the progression of the disease, it's done by the doctors. So that's why we like when you see the doctor on a regular basis, perhaps 1, 2, or 3 times in a year, they're going to monitor the progression of the disease. And they use this scale. They check the symptoms that you have, what the complaints are you presenting, and they use this, what is called Unified Parkinson's Disease Rating Scale, and they will assess, some motor aspects of your daily living, okay, activities of daily living. For example, they want to check your speech, you want to check the rigidity, they want to check how you're walking, how you're transferring from a seated position, if there's any tremors, how they are presented, your speech, your swallowing, those things, a little bit about the cognitive aspect, the cognition, how you walk, if you have any freezing, those things. And then they will come up with always like a score, and they will give a little bit more hands-on regarding like which stage the patient is. Okay. And then this is something that I think it's important for you to know. Okay. Regarding the PD progression, PD is a lifelong and progressive disease. So we know it's going to get worse over time. Slowly, but it's going to go worse over time. The experience of living with Parkinson's over the course of lifetime is unique to each person. So don't compare your journey or your loved one's journey to anybody else, because everybody is running their own schedule. Okay. As the symptoms and progression vary from person to person, neither you nor your doctor predict which symptoms you will get. Because sometimes people ask me, I will get that, I'll have this problem, it's hard to tell. It's hard to tell where we go, in which direction we go. So when you get them, or how to severe they will be, so it's going to depend how the disease manifests and changes by individual. Okay. The timeline for those stages also varies. So what we know so far, most people go up one stage every 2 years. Okay. So we have 5 stages. So every 2 years, go up one stage. However, on a stage of 2, the research tells us, people can stay 5 years around that. So you just buy more time, and 1/3 of people can stay on the stage 1 or 2 up to 10 years. So that's why, the disease manifests differently from people, from another one to other. So that's why those things are important for us to know, because if we compare, oh, how long does have Parkinson's disease? I'm going to get there, this is going to happen to me. No, because you can stay one stage for 5 years, 10 years. It's the research is telling us, or maybe one stage shorter, So, but how you approach the care will manifest a little bit more proactively how to kind of postpone the advance of the disease, the progression of the disease, if we may. Okay. So, and one thing that's also good, it's good for knowledge base, in regards to the subtypes of Parkinson's disease. Okay, there's different ways to name that. I'm going to use the classification based on the symptoms. So, if your Parkinson's, it's more tremor predominant, this kind of Parkinson's have a slower progression, okay, and a better prognosis than other types. So if your Parkinson's starts with more like tremors, so the disease will impact the quality of life later. So you have a little bit more prognosis, less progression, okay? The bradykinesia predominant, meaning like, if you don't have much tremors, but the quality of your movements, decreased throughout the years, so it's like slow movement, difficulty initiating or completed actions. The bradykinesia, creates a little another definitions for this kind of symptom prominence. So people with bradykinesia, they will likelihood to have more falls, okay, and also they might experience, mild or inconsistent resting tremors, and then they tend to experience a higher incidence of actional or postural tremors. Later on, even though the disease is more like towards the bradykinesia, the slowing of the movement, the tremors might be more prominent later on the disease, okay? And then they would not just be resting, but like, for example, when you want to move, you see like you want to grab a cup of water, the tremors are there, and it's hard for you to kind of like grasp, because the tremors are happening, not just when you're resting, but also when you are moving, okay? The ones that have more like what it's called postural instability, engage difficulty, it's called PIGD, okay, are those that have more issues with balance and freezing, okay, with the shuffling, the foot feels like stuck on the ground, those things. And then those people, they often mild, no absent tremors, more difficulty with the walking, okay? And this kind of the disease shows a little bit more like faster and more severe progression of the symptoms, because of the gait difficulty, there's more risk of falls, okay? And also a greater likelihood to develop more cognitive impairments and dementia, okay? And then it's also correlated to higher rates of autonomic symptoms, for example, blood pressure, regulation, some, problems, the gastrointestinal issues, for example, incontinence, those things, all right? And difficulties with heat regulation and interrupted sleep. Okay, so for this kind of, when the freeze and the shuffling, it's more prominent versus, the tremors and the bradykinesia, the prognosis for this one is a little bit more rough, okay, versus the other ones. And then the REM, sleep behavior disorder, is the one that, was part of like the prodromal stage when the motor symptoms were not there, but people were acting vividly, during their dreams. So people act out their dreams and move significantly while they sleep. So for example, you see here, it's just like a picture that, really shows us graphically, how's that. So you're sleeping and you think like you're playing soccer, and you just kick, throughout the night, those things. It's just like a vivid dream as you sleep. And those people, they have more to experience autonomic dysfunction, okay, like the blood pressure dysregulation, and also the incontinence, and then after olfactory loss, like the lack of smelling and some depression. And then the RBD Parkinson's are nearly 3 times more likely to experience mild cognitive impairment than people who do not experience the REM sleep behavior disorder. Okay. All right. So we talk about the stages. We talk about the subtypes. Okay. And now, what's the game plan? There is or supposed to be a game plan for each stage. All right. So just for you to understand a little bit, what's the clinical scenario for the first stage. Symptoms are pretty mild, mostly one side, if it's stage 1 of the body, stage 2, both sides. Stage 1, no, I'm fine, everything's okay, and stage 2, a little bit bothersome here and there, and like nothing major is still happening. all right? In this stage, what we're gonna need it? First, disease education, lots of knowledge base, information, so what to expect, and also, how to be on top of your game for that stage, okay? And then comes with that knowledge base, be part of some support groups if they are available, okay? Our clinic offers, in Fort Lauderdale, every first Wednesday of each month, PD support group for caretakers. So your loved ones are more than welcome to join us. So get some knowledge, some information, share their experience, and empower other caretakers. All right, and especially on this stage, what needs to be done is a change in lifestyle. What do you mean with that, Lenny? So you have to add a physical activity in your schedule. All right. Perhaps you might not need physical therapy, occupational therapy, speech therapy as of now, but you might need on this stage some sort of pick like a sport to practice. I'm going to do running, I'm going to do biking, I'm going to, do Tai Chi, I'm going to do pickleball. So a physical activity, it's very important in this on this stage. You have to have that. Okay. Why? Because we know people who begin regular exercise in the early stage experience a lower decline in quality of life. And that's what we want. If we have the power to hold, the progression of the disease in our hands, if we may, it starts with that. So the dopamine in your system will make, the movements a little bit more taxing overall throughout the years. So what we need to do is just force your body to move. That's why the physical activity is so important. So you move, and then, you force your body to kind of like, have that intake. All right. And exercise, it's medicine for people with Parkinson's. So we know at this stage, exercise, physical activity needs to be in place on a regular basis. Okay. And then on this stage, you could go for a therapy screening. All right. I always encourage my patients, even though everything it's fine, which won't be that fine, go check with the PT, OT, and speech and see how's your strength, how's your balance, how's your voice, how's your swallowing, those things. Because if there's something going a little bit off, it's good to already, catch it and try to work on it. Versus later on, when it's a little bit more established and it's a little bit harder, to try to recuperate or recover or, bring back to the normal patterns. In this case, for example, my approach when I see a client who has Parkinson's and, they're in mild condition, I'm always gonna say physical activity, and then I'm gonna check the normal scores, I would say, based on their age, to pair them to see where they are regarding their functional mobility, and if there's like something that's go a little bit, off, and then we call for physical therapy or we call for occupational therapy, and then so later on they'll get strong again, and then they won't need it, perhaps they will just need something for maintenance, and that's when the therapy screening, it's very important for at least annually, where we are regarding, your functional mobility, okay? And then stage 3, what's the clinical scenario here? Mostly still independent. However, the activity of daily living, okay, those are, for example, walking, bed mobility, dressing, cooking, driving, those things, showering, shaving, those things, now become a little bit more taxing or taking longer. They're still able to do those. They're still able to be independent. However, it's a little bit longer because of the bradykinesia, because of the symptoms are more evident, the weakness are taking place, the rigidity is there, and disability here, it's mild to moderate. And the main aspect for the stage 3 is the falls, so the falling, the episodes of falls already happening, and something needs to be done because we know it's a significant milestone with deterioration in quality of life. What I always tell my patients, we just need one bad fall just to become a nightmare. And then you don't move well because you broke a bone, broke a hip, and then, uh, uh, because of that lack of mobility, you have like a further deterioration of your, functional mobility and your strength of those things, and the quality of life gets impacted. All right. So in people with Parkinson's disease over 15 years, 80% of them have recurrent falls. It's a lot. All right. And at this stage, exercise and physical activity is still very important. However, at this point, not independently anymore, but now under supervision because of the safety aspect, right? We don't want the falls to happen, all right? The therapy at this point, it's a must, because we have some weakness already in place, some balance problems, as we know. Okay, we have to train the balance. Those people that train their balance, they get better. Okay, which is the importance of the therapy. Okay, and then take fall prevention measures, which is now selecting an assistive device. Perhaps they start with canes and graduate for walkers, four wheel, two wheels, standard, and that go like you go work with that with your therapist based on your functional mobility and the home safety. Sometimes some railings, some bed railings, some carpets, rugs and stuff needs to be removed, or some clutter environment needs to be reorganized, clean to help the patients to, perform well on their environments. Okay. In stage 4, which one in stage 5 are the ones that are more advanced, okay, stage. So the clinical scenario is like, at this stage, there's some motor fluctuations, meaning like you have episodes when you move well, you feel good, and episodes that I feel like worse. The medications are not working as before, right? Like the honeymoon of the medications has ended, and then now you present a little more side effects of medications, perhaps dyskinesia. Dyskinesia is kind of like a dance-like movement when you have medication, already kicking in your system, or dystonia, meaning like there's some sort of like cramp in your hands, your feet, like because the medication's there, you have and you experience a little more of those episodes, and they're more evident, more present, and they're, I would say, more bothersome. And disability is always solid there, and around the clock care is needed. At this stage, still again, I'm in the advanced stage. You mean that I should not exercise? No, you should. Exercise still prescribed, physical activity is still prescribed. You still can do lots of exercise, lots of walking, but now under supervision, because perhaps there's more like risks involved regarding the falls, regarding other things, and then the therapist, or somebody else with you can guarantee your safety so you can move. All right. The therapy regime, it's important to have the PT, OT, and speech there for you to help you. Okay. And then there's a few things that we have to really be, aware that it's life-threatening at this stage. The first one, fallings, which was before in stage 3, but now more risks. Aspiration and risk of pneumonia, like drinking or eating something, and then goes to, instead of to the digest system, goes to the lungs, and then goes to the hospital. Is the picture is not good, so, and there's a real like a setback with that, and some sort of infections, that goes UTIs or and other kind of infection that we have to control that, because those things, throw your Parkinson's off, and for sometimes they can advance the symptoms. Okay, so just have to be a little bit more cautious with those and avoid anything that could cause some life-threatening situation. All right. At this stage, the seat device, it's needed. It's a must. It's not a choice because of the risks that we are minimizing. So the walker and the wheelchair, they needs to be part of of that mobility, and some sort of like caregiver education. Sometimes the care partner needs a little bit more education how to manage and help the loved ones, or sometimes we have an aide come to the house, helping to take care of the patient, so that care is needed. Help them to dress, help to them to bathing, those things. It's important to educate, the caregiver, and also, for stage 5, a little bit more social work, I would say, task related to palliative care, which is more like, helping to relieve symptoms, while still allowing for the treatment of the disease. Okay, especially if patients might have pain or feel really uncomfortable with some sort of, some symptoms, the palliative care helps with that. And sometimes the hospice care when, the patients, are really, the disease are really advancing and there's no much more to do, but however, some care still needs to be in place. And then, that could be, in a range of like six months, before anything happen regarding death or something related. Okay, but I have seen patients, under hospice care, being in and out, which it happens. Okay, doesn't mean that you under hospice care you just have 6 months of leaving. No, you can stay on and off, and it happens quite often. Okay. All right, I'm gonna end my part here for now, and I'm gonna ask you guys if you have any questions that I would like to answer those, or anything you would like to say, or me to come back on the slides, so to show you anything else that call your attention. Just unmute yourself if you wanna ask anything, and let me know. You guys are too quiet. Come
The problem
on.
is
No.
you're asking me to think. That's the problem, Lonnie. Asking me
Mhm.
to think is a problem. Just ask my wife. Uh,
Okay.
the presentation was really the best I've ever seen of the total picture. Very nicely done. Thank you.
Right.
I've been at this since 2018 and trying to put the whole picture together periodically. But this was a really nice presentation. It helped out at the different stages and how they fit in and looking at the difference in transition from one stage to another. That has helped me personally. So I want to say thank you for that. The big question, I think, also comes in for the training for the caregivers.
Right.
And unfortunately, a lot of our caregivers are people who are forced into the situation because they have relationships with the people who've been diagnosed with Parkinson's. And I think that's a real needy stage for education in that group for the people who are with us and who have to put up with it. And I say have to put up with me. Um, but it helps tremendously for us to have more of this kind of thing for the caregivers, and especially in the formatting that you're doing, so that it's an opportunity for them to still be able to be around the house or whatever their Parkinson's patient is. And so I think that this would help a lot to do more of this if you can, and get a broader picture out to the public,
Okay.
who, by the way, also seem often to feel disassociated from what's going on because the focus is always so much on the patient, and that caregiver person is a real big part of their life.
Absolutely. I wanna endorse three things what you said. Okay. The first one, we know Parkinson's disease is a family disease.
Mm.
So that's a good point that you brought up. It's not just the person who has Parkinson's who is affected. Everybody's around them, their kids, the wives, husbands, partners, everybody around them will be somewhat affected. And that the care should not just be focused on the person, the people with Parkinson's, but the person also who's taking care of the person with Parkinson's. That's why education is so important. Not those for the only for the folks who have Parkinson's, but those that are taking care of them, and that goes around, with the husbands, wives, partners, but also, the aid that it's coming in to help them, because if they don't know, how to approach better, the disease, it's just going to be another barrier. It's going to be another obstacle the person has to face on it. So I'm very advocator for give education, because that helps to burden, a little bit of, the diagnosis of the heaviness that Parkinson's, can bring to the family, and also help us. That's the second ones, and I'll help you to manage your expectations. So one thing that it's important to know: you don't die because of Parkinson's, you die with Parkinson's. So that's kind of like, in some way a good news, in a way that, okay, if you manage Parkinson's well, you can live, longer. You can live, like 5, 10, 20 years. I have patients approaching, 30 years with Parkinson's. All right. So, but what's solid is that piece of education, a little bit more approach with everybody around them. That's where the caregiver comes to be educated, and also, a better management, like managing expectations, knowing that, okay, for example, when I mentioned about the stage, what to expect in each stage, and those, it gives us a little bit more peace of mind that, we can stay longer one stage. Doesn't mean that, we're gonna just go jump to the next stage every year. No, we can kind of like manage better with those things, if we're a little bit more proactive with the physical activity, medication management, and then following up with your doctor's appointments, and have always a plan that we stick with, and we perform, and that's where it should go. But what you brought up was very, very important, very, very solid, and thank you for doing that.
I'd like to second those comments. It was a very, very informative session, and I'm glad I was able to log in to listen to it and see everything. And I take it that physical activity is just extremely important to, okay, somebody's in trouble at home then.
Yeah, because the problem is we know the dopamine is lacking there, so which is responsible for movement. How can we place dopamine? First, medication. We take, Rytary, carbidopa, levodopa, Sinemet, those things, very important. All right. And then we force our body to move. That's a replacement of the dopamine. When we force our bodies to move, that helps us to kind of like, okay, let's get dopamine. Whoever I have available there by nature dopamine that my system produce, even though it's a little bit, there's some there, or maybe the dopamine coming from the medication is available for me. Let's use it. How do I use it? Physical activity, exercise. That's the key. So 2 things to be on top of the game: physical activity, exercise, and medication management. Always, taking your medication, right time, following the schedule, perhaps between 3 or 4 hours, every 3-4 hours, and then do that on a regimental basis. And that's very key for a proper management. All right. Anything else, guys? Questions? We like them. Just unmute yourself if you want to speak. Hold on. I see somebody speaking.
Hello, can you hear me?
Yes, we can.
Okay.
Okay.
First of all, I want to congratulate you for that very informative speech. I think you gave us a lot of information And me being a geriatrician, I would say that sometimes physicians don't think that patients that have been diagnosed on a stage 1 or stage 2, and maybe patient even comes on the moderate or advanced stage, needs physical therapy. And I think that all this, with the addition of the therapy at an early stage, will make the patient last longer in life. So I want to thank you very much for this very informative conference.
Absolutely. You're very welcome. Thank you so much.
Mhm.
And to add to that, I would also think that not only will they last longer, but they will have a better quality of life,
Absolutely.
which
They
is
will
really important.
yeah, they will stay longer and make memories. That's what counts. They'll stay present with their families, still traveling, still enjoying, birthdays, good memories, and still a decent quality of life. And that's what counts, So for that matter, you have some power to make it happen. If you follow with the plan for each stage that's required, that's way to go.
This is a reminder. Take my medication.
All right.
This
Anybody
is
else?
an excellent presentation, Dr. Lenny.
Can you
Thank you
hear
so
Doug?
Yes, I heard him.
Take my
Okay.
medication.
I would welcome caregiver and patient education in the relationship. It's especially acute among married people.
Mhm.
What makes a good patient? Good meaning lessen the burden on the caregiver.
Absolutely. As much as proactive you are and you take charge of it, less burden on a caregiver aspect. You're totally on it. So that's why, even if you're already, in advanced stage, it doesn't mean that you should quit and just drop the ball. No, the ball's in your court still. Just make wise decisions regarding your mobility with safety, with a team around you to help you, so you can help your loved ones as well. Taking care of yourself will help your loved one. Very good point.
May I ask a question?
Absolutely.
My issue has been, I've seen my different neurologists over the years. I think I've been diagnosed from 8 to 10 years now. And recently my neurologist put me on an extra booster called Entacapone.
Mm-hmm.
And I don't know if any of your other patients there in this forum are in that medication. But I'm taking 2 carbidopas, an Entacapone 4 times a day, then a CLX, which is a long release of carbidopa at night. The issue is protein affects these medications and absorption of the medication.
Absolutely.
And my doctor wants me to do it every 1.5 to, say I take a carbidopa in the morning.
Yet?
I cannot eat.
No,
I cannot eat for 2 hours.
I have
I don't know if anybody else has the same
a
issue
bunch of meetings.
with their
All right, so,
medication.
I'm gonna
all right.
fact.
Just if not speaking, I asking the question, just mute yourself, please. So what you have to do, perhaps I don't know what's your regime with the schedule. The topic that you brought it's very important because people should not eat protein when they have, the Sinemet carbidopa levodopa, which has a protein-based medication, because if you eat something protein-based, let's say like you get some eggs, eating, they have your medication. When you digest that, your system doesn't know which one comes from the food, protein, or which one is there comes from medication. So you have to have a little bit more empty stomach with that protein. But it doesn't mean that you should not eat. you should revisit that with your doctor, okay? You can have other things to eat, okay, but not protein, okay? Perhaps you can have fruit, you can have all sorts of like, juice or bread, anything like, but I don't think you need to be fasting for 2 hours for those medications. As long as you leave a gap, I would say 1 hour, from your medication regime, you don't have to hold back food. You just have to hold back protein. It doesn't mean that you don't need, you should stop eating protein. You just have to, when you about to take medication, before not have protein on your food, and then afterwards, 1 hour afterwards, when your system is already, digest, the medication, then you can have, food with protein. You just need to be a little bit more cautious with that. Doesn't mean that you should not eat protein. You just have that gap. Well, like for example, I'll give you a scenario. If you're taking the medication, the carbidopa, levodopa, like 8 o'clock, okay? You should have breakfast or 7 o'clock, or should have breakfast or 9 o'clock, if you want to eat eggs. But I'm not eat eggs, have your coffee at 8 o'clock, eat some bread, those things, and you can have your medication, but just not take protein food in combination with your medication.
Yeah, the other issue is that I have cancer,
Mm-hmm.
and the medication I am on now, it takes away all my testosterone,
Mm-hmm.
and that of course takes away my energy. So
Mm-hmm.
I'm fighting two battles here, and
Right.
trying to find the right timing to take everything, because I also cannot take my cancer medication within an hour of eating food. So
Right.
that's my dilemma right now. So I thank you
Yeah.
for your information. Appreciate
Absolutely.
it.
Bring that to the nurse, or even the doctor, from both sides. I would say from the neurologist aspect and also from the oncologist, to get like the best approach for you, especially regarding what you eat, and to give you that boost, from the food, from energy, decrease fatigue, those things, so you can fight better, and try to hit, those two birds with one bat.
Yeah, we're addressing that every time I meet them, and most of my doctors I meet every 3 to 4 months. So
Very good.
we
And
try to address
both
that.
of them, and both of the conditions, physical activity is always helpful to
All
fight.
right. Thank you very much.
My pleasure, June. All right. Anything else, guys? We're good? All right. So let me just finish here then. So next topic, next webinar, don't miss that, will be February 21st. Okay, we're going to talk about falls. So then watch out for that, and we're going to just share information about it. Okay, and because we don't want people to have falls and create other problems. All right, and what to do to be proactive with that. Okay, so same link, same process, and feel free to invite people to join us. Okay, and we offer a few things here that I want to share with you. Our Parks exercise group class in Fort Lauderdale happens every Mondays. This one is $20 per attendance. It's more like advanced high level class. So the only prerequisite that we ask, no need office device. So because we're going to be able to move independently and safely. So we don't want anybody to fall because of the exercise, of the intensity. All right. And then on Tuesdays, 11 a.m. and Fridays, 2 p.m. with the same link that you access today, we have this free online exercise class that you can kind of like, as a medication you take every day, you have those 2 days, you can take advantage of that for free. Okay, and as I mentioned, we have a support group for caretakers, which happens every first Wednesday of each month, and the next one is February 7th. Okay. And this is our information. We have 2 offices, one in Fort Lauderdale, near the Holy Cross Hospital on Federal. The other one in Delray, also on Federal Highway between Linton and Yamato. So if you wanna contact us, this is our email, contact@drphysiotw.com, our phone number and fax number, okay? And we provide physical therapy, occupational therapy, and speech therapy, plus other exercise approach classes, you know. And thank you, everybody. Thank you
Thank you,
for
Lenny. Very good job.
my pleasure, Joe, for your attendance. You know, I appreciate
Thank you.
guys. My pleasure. And then I hope to see you on next webinar or in a clinics, you know, in exercise groups or support groups. Okay. God bless you all. Take care. Have a nice day.